probably the last, it's just probably a repetition of what we have said. I've got the names there, I shouldn't have had the names, but again, just recap what we have talked. So gout, and I've told that gout spares the articular surface and it involves the subchondral areas. So the articular surface is still maintained. Look at this one, it's quite pristine. The joint space is fine and you have erosions just below that. Again here, if you look at it, there is this joint there, the space is maintained and it's just subcapsular. And then you have got tophies, which are characteristic. This is what when you are saying what is the definitely likely, less likely. So this is the characteristic appearance of gout. No other features will basically relate to the appearances seen on in gout patients. What is this? Aneurysmal. So now again, going back what I said, location is very important. So this is in the metaphysis. If it was slightly abutting this side, this would make a diagnosis difficult. Why? Because I said if this is involving this and if it is more advanced, it erodes through the epiphysis. Epiphysis is natural barrier created by God. So basically you've got the epiphysis, so all the, even if it is primary tumor, it is with difficulty passes through, and when it passes through, that is advanced disease. But that is the barrier created, and you need to know if it is in the meta only, so it's likely to be a bone cyst. If it goes slightly lower down and involves the complete metaphysis and the epiphyseal line, and maybe sometimes goes into the epiphysis here, then it becomes a GCT. And if it's only involving the epiphysis here, then it is a chondroblastoma, and it's normally in a young child. Again, this one is cyst with multiloculated cyst, and we're sparing the metaphysis here. This is again the enchondroma, which is expanded and involving the bone. The cortex still slightly expanded, but still you can see it's still intact. So it's not a malignant process, it's whatever it is, it's a benign process. The margins are still maintained. This is again in the spine. Gopi showed you it's not a malignant process. You see some sclerosis. It's not, you've got sclerotic margins, so whatever it is, it's a slow growing. It just encroaches the dural sac, but it's not completely destructive. The appearance doesn't look like a destructive. GCT in the spine, if you see something involving and you think it's a benign and involving the posterior process of the vertebra, is characteristic of giant cell tumor. Again, this is a bone cyst, it's just projected, so still sparing the meta, so it's at the metadiaphyseal junction. MR is very characteristic. You get this layering. So white is the fluid. This is basically deranged fluid with proteinaceous. So white on this, because on MR is fluid, and you get this layering is diagnostic of cyst. Again, this is again cysts. There are different variations, different places. Now what I was telling you, so now the position has changed, involves, and is almost involving this, and the physis is joint, so it's not chondroblastoma, but it's giant cell. Sometimes it becomes difficult to separate chondroblastoma with giant cell, but you know, this is adult, and it is not only localized in this region, but it goes into the metaphysis, and this is a giant cell. If you look at this, and if you remember what I said about infarct, it's very difficult. But if you look at it, it's well defined. Here the margins, lateral margins, is eccentric, involving and based on the cortex. very commonly seen in bone scan. And if you look at the spect CT and you look at the CT component, it's very characteristic and is diagnostic, and it's normally at the distal ends of the long bones. This one is a bit difficult, but this is fibrous dysplasia. Normally you say whatever lesion you see in a bone which is lucent and in young patient, and it can be in the elderly, but they are typical sites of fibrous dysplasia. You can commonly seen in the brain, in the skull, and they are towards the sphenoid or the clivus. And if you come down ribs, you can see it becomes difficult at times to separate it from the aneurysmal bone cyst, and then you can have anywhere in the long bones. The characteristic feature of these are you've got lucent areas with well corticated margins. So you've got cortical sclerosis with reactionary changes and lucent lesion there. Now, question would be, if it is hot on bone scan, you see this appearance, and then you say, is it malignant or not? So it is at times difficult, but if you look at it, what Gopi said, you look at the zone of transition is very important. So here is a very narrow zone of transition, meaning you can define the margin here, and this, with this margin, you can, it's very narrow. But on the other hand, here it becomes a wide. You can't appreciate where the margins are. It goes all the way down, 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 and the cortex still thickened. So it may be suspicious. You can't exclude, but the appearance are suggestive of fibrous dysplasia. Again, this is GCT extending all the way here. This is whole. What is this? Yes, very good. It could be, but it is a cyst, bone cyst. Yeah, that is a good differential. And eosinophilic granulomas, again, they will be in a young patient, and they will have lucencies, they will have margins, sometimes diffuse, and they will be like brown tumors if there is a patient with hyperparathyroidism, so it becomes difficult. The clivus is another side, and sphenoid again shares the same sites with fibrous dysplasia. Sometimes becomes difficult, but age basically separates one from the other. This is difficult, so this is chondroblastoma of the calcaneum. So any cystic lesion is most likely chondroblastoma in the calcaneum. So this is very typical. If you see this young patient, you see this, and you see cortical tubercular thickening, cystic formation, some are well defined, fibrous dysplasia. What's that? Fracture. Sorry? Old fracture. Where? So you've got this whole thing. So now the question is this normal or this is normal? Yeah. So the cortex is normal, but if you look at this, you've got a transition, it becomes thinned out, so the abnormality is here. Yeah? And then you've got some tubercular sclerosis. So it's basically is probably transforming from one to the other. So you've got cortical increased tubercular thickening, you've got lucency, and this Paget's, which is probably transforming from acute to chronic. What's that? Diagnostic, characteristic, typical of Paget's. If you see on the CT, this is correct. So basically, what are the features of, is just probably just to recap, widening, thickening of the cortex. So that's the anterior cortex, that's the posterior cortex, that's the skull. So there is widening of the buccale. So these are the trabeculae, these are coarsened throughout. So any coarsening of the trabeculae are suggestive of Paget's with expansion of the bone. So that's that they say in history. If a person is wearing a hat, so they say the hat has become small because the cranium has increased in size. So that's how they used to diagnose people earlier. What's that? I've written it there. So it's typical diagnostic of osteoid osteoma. The definition is eccentric, cortically based, cause cortical reaction, making it thickened. You've got a nidus there, lucency, and this is what you see on bone scan as well. What's that? Anything? Any guess? Why guess? Where? Where? Here. Yes, it's very characteristic. So you see cortical thickening, elevation, and if you do a CT, you see the features. So osteoblastoma, similar appearance, bone island. Sometimes very confusing, as Gopi said. It becomes difficult, but if you see one or two or three without any history of malignancy, they are bone islands. Characteristically, you see in the skull, pelvis, and vertebrae. So enchondroma, sclerotic areas, very common place where you see. What's that? 50-50. It could be a Met or Met would be. Pedicle is normally what I was taught. Any lesion, sclerotic lesion you see in the pedicle is Met. Is it a Met? It looks like, or it doesn't? Yes. Sorry? No. No. You need to go back now. Sorry? This one? But are you talking about generally? No. Generally, there is a classification. So if you have a primary, you know there is a history of malignancy. You go back to the basics, what primary it is. So now I have to recap. You have got a spectrum, you've got lytic, you've got sclerotic next. And some tumors could be lytic or sclerotic. So you can see in patient both. Neuroendocrine tumor, if you start, this is how I remember, you can overlap. Neuroendocrine tumor or sclerotic. They have got very characteristic appearance on CT. The arterial, when you get contrast, the arterial takes 20 seconds scan and enhance. Very early enhancement. If you see a flush on arterial phase, it's neuroendocrine tumor. Or if it is quality with background of liver cirrhosis, it's KCC. These two, they follow exactly the same pattern on CT. Now, Coming back to sclerotic lesions, during the time, breast can have little and sclerotic. Osteosarcoma can have sclerotic metastases. Bladder cancer can have both, predominantly lytic or sclerotic. Renal cell carcinoma can have sclerotic. Thyroid cancer can have sclerotic. And the rest in the midline, remember, can have both. Breast can have both. So, sclerotic, that's why sometimes you can go to Paget, sometimes it becomes very difficult to see, and sometimes you don't know whether the Paget has dysplasia. So it's very important when you're putting a report, when you say in the absence of primary, and even most of the report that you keep. So I could have a caveat at the end, and if I see some lesions, some update in the bone, I cannot differentiate whether these are in the ligament, and I can't see a primary, so I put a caveat saying that the absence of the primary, the absence of primary, these are primary. But if there is a non-primary, they haven't told us, they're respected it. So they are maybe 50-50. So not all sclerotic are benign. So this is a benign. I could have reported that as metastasis because the site is there, but this I got it from. It's not mine, but it's documented on the internet as benign osteoid osteoma, or not osteoma. These are multiple sclerotic areas, and this is a very characteristic appearance. If I show you the coronals, I've got one. So these speckled calcification in both sides of the joint, these are very characteristic of osteopoikilosis. It's very commonly seen, and it's both sides. It's like candy wax appearance. So candy wax, basically when you burn a candle and it drops, the wax drops, and you see those speckles. It's exactly what you see on a paint film. It's hereditary and is benign. So again, what I was saying about Paget's, look at the cortex here, look at the cortex. The initial thing is this cortical thickening. Look at the trabeculae, they are quiescent. Look at it here. Look at the difference between these two, and they are expanded. So it's typical of Paget's. Paget's and bone scan, Paget's in the spine. So sometimes you don't see any changes, but on bone scan you just see some increased uptake, and if you do a spect CT or a planar, you see uptake. This is because of the stress, and this patient has got, so you've got this ulna, so ulnar deviation of the metacarpophalangeal joints of the distal phalanx. So basically they flex the contractures of the muscles on this side and causing this Jacob's arthropathy. We were discussing about the Charcot, so I just included this. So Charcot's joints is multiple Ds. So destruction, dense, degeneration, dislocation. So all the Ds you can think of, it comes into, if you've got all those, then it is characterized as Charcot's joint. It's complete destroyed, destruction, and you see calcification. So either this patient is on prolonged steroids, renal failure, or most commonly a diabetes. The other thing we were discussing yesterday about Lisfranc. Lisfranc is fracture dislocation. It's not disruption. Charcot's is disruption, destruction, and degeneration. Lisfranc is basically fracture dislocation, and it's lateral dislocation, and it deviates all the cuneiforms and metacarpals laterally. So it's an emergency and needs to be corrected. Otherwise, they have avascular necrosis. Again, you've seen this, and that's the end.